We are now to our point-counterpoint portion, and we're talking about should NAION be treated with medications. First up, Dr. Judith Warner.
Thank you for inviting me. I am a little trepidation here about my esteemed colleagues and their strong opinions on the matter. However, my side of the argument is anterior ischemic optic neuropathy should, and I supplement maybe could, be treated with medicine. And medicine is a really nice broad term, I like that. So anterior ischemic optic neuropathy is the most common cause of sudden vision loss in the over 50 crowd. While this is true, it's also thankfully not truly common. Because of its relative rarity, it's been very difficult to study, and its outcome varies tremendously from 20/20 to no light perception vision, and there's spontaneous recovery of some degree of vision in almost all patients. These two factors, the rarity and the variable outcome, have contributed to the paucity of large controlled studies. The ischemic optic neuropathy decompression trial, for instance, enrolled 258 patients to obtain reliable results. And there's still discussion of that. The pathophysiology of AION is unclear. It's clear that there is a ischemic component as a final common pathway of the vision loss, but the initial triggers are uncertain. People can have it associated with trauma. There have been proposals of posterior vitreous attachment, venous obstruction, medications, et cetera. Because of this, treatments have focused on the clear component, which is the optic nerve swelling and the axonal ischemia and death. Central nervous system injury is notoriously difficult to treat once it's started. In the absence of perfect treatment of the cascading spiral of death, prevention of second eye involvement would be useful, with recent studies suggesting a higher risk of second eye involvement in patients with optic nerve drusen and those with untreated sleep apnea. The world of stroke neurology, the other major ischemic event, is littered with failed trials of neuroprotection, crashing into oblivion when they're saddled with the dual burden of trying to reverse a process that's already underway, and also medications not being used in rats. The brave basic scientists like Joyce Liao working on experimental AION are careful to apply real-world requirements to their proposed solutions, with some benefits in rats treated after ischemic optic neuropathy. They have found rescue of optic nerves with endoplasmic reticulum stress pathway blockade, BDNF receptor activation. Others have trialed minocycline and puerin. The most recent failed trial in humans involved a small interfering RNA to block the caspase pathway, the QUARK study. Various other trials for acute optic neuropathy with smaller numbers of patients have also been unsuccessful or contradictory or inconclusive, including normobaric oxygen, erythropoietin, heparin, warfarin, triamcinolone injections, and brimonidine. So the major current controversy roiling our community after 10 years has been the use of steroids for ischemic optic neuropathy, and I suspect that's the main goal of our inviters to discuss this. Dr. Hayray kept very careful records on his patients. He was not able to fund a prospective study, but he did a very extensive retrospective study of his patients over the course of 20 years. He collected records from over 600 patients and patient-selected treatment with or without steroids. About 300 were treated with steroids. And in those 70 patients who were treated within 2 weeks of vision loss, whose vision was 20/70 or worse, compared to the 71 untreated patients with vision 20/70 or worse, more treated patients had improvement of 3 lines of Snellen acuity at follow-up. Patients treated after 2 weeks had no benefit. Patients with better vision had no benefit. One can conclude, therefore, that in this small subset of patients, which was only 20% of patients who were treated, there might be benefit from steroid use. This study had a very small number compared to the ischemic optic neuropathy decompression trial, however. A discussion of the medical treatment of ischemic optic neuropathy would be incomplete without a mention of trials for improving vision after an event of ischemic optic neuropathy, and this is a terribly exciting world which may be fruitful. There are various studies ongoing, including ones that could be found at clinicaltrials.gov. stage 3 efficacy trials. Don't forget
Judith?
risk factor modification and second eye prevention, maybe with aspirin.
Dr. Miller, what do you think?
I feel a little bit like Fox Mulder in the X-Files. I want to believe, we all want to treat our patients to make them better. And even when we don't have a treatment, we give it a try. We did that with optic neuritis, and the optic neuritis treatment trial showed that low-dose prednisone didn't do anything, and high-dose prednisone sped recovery, but that was about it. The same thing, I think, is true of steroids. Hayray and Zimmerman, back in 2008, as you said, had some success in treating this condition, which has about a 35 to 40% spontaneous improvement in the first place. Gina Riboletta was unable, not tiny little study, 10 patients, was unable to confirm that, nor was Mohammed Pakravan in Tehran with a somewhat larger study. So the problem is we can treat with steroids, but there's no good evidence that they do anything at all. And I guess the real issue is do no harm, primum non nocere. So I have no objection to treating with steroids if there are no contraindications, but don't fool yourselves by thinking that there's clearly going to be a benefit, and don't stop looking for something that is even better. You mentioned brimonidine. That's not been shown to be helpful. Erythropoietin and erythropoietin agonists might be, but again, there are no data that confirm this. So I want to treat with medication. I think it should be, NAION should be treated with medication. I just don't think we have any medications that we can say are consistently, if at all, beneficial.
So we only have a couple minutes left. I don't know if the rest of the panel can.
Yeah,
put their
I'll make
comment
just a
on it
couple of
quickly.
quick comments. I agree that there's certainly no Class 1 evidence to support this, but as I have said out loud about getting an MRI scan if I had a 6th-nerve palsy, if this were my eye and I had a swollen optic nerve and I had vision loss and maybe even vision loss that were getting worse, I would treat myself or have myself treated largely based on anecdotal experience and my opinion that this is not a single disease that represents a stroke in the optic nerve and you're not going to make stroke better with steroid. We all recognize that there's a cascade that's associated with NION and worsening in vision, and whether it's disc swelling or macular edema, there's at least a theoretical perfect person whom steroids might hurt. So I do offer it to patients I have a discussion, let them help me decide, but with patients with severe vision loss or progressive vision loss. Judith didn't mention it, but there was a paper done by Saxena in Ophthalmology in 2018, which was a small series, 20 patients. He did show a significant difference in the rate of resolution of disc swelling and slightly better VEPs in patients who were treated with steroids. So I offer it, and it's what I would want for my eye.
Okay, well, I guess I'm like Lynn. I'm the closer. So what do all these things have in common? Ready? Acupuncture, aspirin, anticoagulants, thrombolytics, pressors, vasodilators, steroids, intravitreal steroids, anti-VEGF treatment, optic nerve sheath fenestration, optic neurotomy, release of vitreous traction, dilantin, L-DOPA, topical brimonidine, hyperbaric oxygen, okay? Those are all unproven, actually in many cases failed treatments of NAION. I have to amplify what Neil said in that I think we are sort of, as physicians, we become desperate and we maybe don't want to disappoint our patients. Of course, we're smart people and there's all this advertising on TV, the great progress that's being made in all these different treatments. Surely there's got to be some treatment for NAION. I think we need to be honest with the patient. And I think the last thing I would put out is what we say in our Hippocratic Oath that Neil already alluded to. First, do no harm. This isn't an aging population. These medicines are not without risks, particularly systemic corticosteroids. So I think without evidence, without Class 1 evidence, I think we're on very shaky ground. And although, as Neil said, we'd like to treat this condition, at least in 2019, we have no evidence that anything works in the treatment of NAION. End of story.
Boom.
We want to thank our panel for a very enlightening
I
discussion.
do love to have my VEP get better.
Come on, who was the last patient?
Okay, next up, our speaker is Dr. Kevin Lai from Indianapolis.
All right, I'd like to thank the moderators for inviting me to present and our esteemed panel here for commenting. So I have the distinction of presenting a case on a patient who came in and said, they told me my optic nerves are swollen. So I have no financial disclosures. And so this patient comes in and says, hey, well, my doctor told me that my optic nerves are swollen. Didn't know any problems there. So this is a 17-year-old Caucasian female who 3 weeks prior to presentation had a rapid onset of bilateral eye pain, headaches, and binocular horizontal diplopia, and went to the ER after talking with her primary care doctor, who said, oh, well, you know, maybe it's some main concern there, and they had a CT scan that was read as normal and diagnosed with a migraine and sent her home. About a week and a half after that, the headaches and the double vision improved, but she still continued to have blurred vision. So at that point, she decided to self-refer her to an optometrist who noted optic nerve edema in both eyes and was referred for evaluation. Okay, when she presents to the office, she primarily complains of blurred vision. So a few other things in her history that might be important would be that she complains of constant blurred vision that worsens with bending or coughing, some whooshing type sounds in her ears, but no weight changes and no recent travel, illness, or trauma. Okay, her past medical history is only significant for seasonal allergies and acne. Her rest of her history is really not all that significant, but her medications, I want to note, she is on some allergy medications, including recently stopping a steroid nasal spray and then minocycline for her acne. So on her examination, so she's moderately overweight, but not terribly, and then she's also got normal blood pressure, and her visual acuity and afferent function are normal. Her visual fields initially are full to confrontation, and her anterior exam is normal. So I'd like to first stop here at this image and invite the panel to speak a little bit about the optic nerve appearance and comment on some of the thoughts that they may have.
The nerves are swollen. But importantly, she's got excellent afferent visual function and crossed eyes by report, and this is elevated intracranial pressure until proven otherwise.
I'm bothered by the fact that she presents complaining of blurred vision. As has been spoken about earlier this morning, in general, papilledema doesn't cause blurred vision unless there's significant disc swelling to cause an enlarged blind spot, or the papilledema is caused by an intracranial mass, maybe in the third ventricle or something like that. So I worry about the message this sends to everybody, because I would expect somebody with standard papilledema, if they've got if they complain of blurred vision, I would have expected substantial disc swelling, maybe hemorrhage or exudate in the macular or submacular fluid or something like that. Having said that, I agree completely with Judith. This is papilledema until proven otherwise. The patient doesn't have to be obese to have a pseudotumor picture, but of course, again, if you're going to say this is papilledema until proven otherwise, then you have to say it's a mass lesion until proven otherwise, and then you have to go from there. There are other issues, of course, as well, including the fact that she's treated with a drug that could be associated with increased intracranial pressure, and that's minocycline.
Just to play devil's advocate, these discs are swollen, and I would proceed with a workup for papilledema. The little crescent-shaped hemorrhage next to the right disc, which looks deep to me, that's something I generally favor pseudopapilledema a little bit with. Maybe she could have both swelling on top of it. I don't think you have a choice here but to aggressively pursue papilledema as a leading diagnosis. But I think what the panel is reacting to is that this is not the discs we were expecting to be shown in a young person with a rapid onset of elevated intracranial pressure symptoms. And this is more like the disc that went to the optometrist for glasses and They looked in, it's, yeah, I think it's swollen, and there are some discs you just can't tell, and I would proceed in the papilledema direction, but between the hemorrhage, the general appearance of a lot of those vessels as they relate to the disc swelling, and the disconnect between the history, I think there's some room to be not surprised by some zigs and zags in this case, I'd say.
Does the 2015 corrected vision reassure you at all?
I guess it's just a question of why she was complaining of blurred vision if she's 2015, and whether it was just the transient visual obscuration she was having, that, blurred vision, everybody has blurred vision, or will offer that as part of their afferent complaints to an ophthalmologist, but there's just, the history isn't perfect for these discs, and that's just the way I'd leave it.
If she's having bad headaches, some people just sort of get a little bit of blurred vision
Yeah.
because they're having a headache. Maybe that's it. But it's something that should bother you.
All right, so here are her visual fields that we obtained, which show some mildly enlarged blind spots and some just kind of noise in the total deviation there, so it's a little bit depressed. So I'd like to open up the audience response question here. And so the panel's already alluded to some of this. What would you think is the most appropriate next step in management?
So A would be MRI brain MRV, B, stop current meds, C, lumbar puncture, start Diamox, or urgent surgical treatment with optic nerve fenestration.
Okay, panel, do you have any other comments on that?
I think I'd certainly agree with that, and I think everybody who would see this patient would have to go in that direction. It's a thin patient. The minocycline-associated pseudotumors are more common, and also it's not a patient who's gained weight, but she certainly sounds like she has the setting of being overweight, which in my own experience, I'm not sure if it's true in the studies, is a slightly greater risk factor for the minocycline-induced version of it, but I don't think there's anybody here who would just say, stop the minocycline, lose 5 pounds, and come back in a month. That'd just be too risky for someone who could have a brain tumor.
And I think the other thing is that if you didn't have access to MR, CT and CTV would be just fine as well. Often physicians will say to me, well, my people want to do a CT as opposed to an MRI. And the answer is you should order whatever your hospital feels most comfortable with. So CT, CTV would be pretty much just as good as an MR or MRV. It'll show you what you need to see.
And she had previously had that head CT in the ER, which was probably non-contrast. Would anyone say that that was sufficient neuroimaging and just stop the drug and watch?
If it's a pure CT, first of all, I'd have to see it myself. I don't think you ever, people used to be worried about the demise of neuro-ophthalmology once neuroimaging came in, and what many people say is we spend our time reevaluating supposedly normal imaging studies. So I wouldn't be comfortable with the report that the CT was good, and you certainly may not see venous sinus stenosis with a pure CT.
Yeah, I think under the bright lights, I would not be satisfied with just the CAT scan. In the real world, have I ever seen someone who had a CAT scan that I could lay eyes on, that was taking minocycline, that I stopped at that point and watched them get better after taking the drug away? Yes, but I don't think that's a fair thing to recommend to non-experts.
All right. So our next steps, we kind of agreed with the thought process, and so we obtained both MRI and MRV imaging, which after review looked completely normal. A lumbar puncture then was obtained showing an opening pressure of 37 centimeters of water, which is high. All of the cerebral spinal studies were normal. So we talked with the patient. We recommended stopping the minocycline. Based off of her symptoms, we also recommended starting her on acetazolamide and counseled weight loss, even though she was not terribly overweight. At follow-up, all of her symptoms had pretty much resolved, but there was still papilledema and mildly enlarged blind spots on her visual field, so we increased her acetazolamide, and then the following month was looking much better.
Would anyone have deferred the lumbar puncture?
No, stay tuned for, what is it, Monday. We'll discuss that issue.
Would anybody have not ordered the venogram or the MRV?
You know, I mean, I think there's no question that the right way to do it is the way this patient was managed, maybe plus or minus adding the Diamox depending on how the patient felt. But I'd be the first to admit there are times when I veer off the typical flow chart of working up papilledema. I'm sure there are exceptions, and we'll see spectacular cases on Monday where the lumbar puncture revealed something we weren't expecting. You know, but in the end, there are the real life of managing something that you have good instincts about. And so there are times when you deviate from it, but I think if you're an ophthalmologist who's stuck making these kind of decisions because you don't have access to neuro-ophthalmologists, and notice I didn't say general neurologists because they're not very good at this disease and making decision-making, then I think you should play it by the books, which you can. If you have imaging, you have IR-guided LPs, if you tell people what you're looking for, you have a visual field machine and a prescription pad to write Diamox, you can easily manage this patient without vision loss and presumed minocycline-induced papilledema.
One thing, and I'm glad you said presume, because we've all seen patients who were on medications that could cause increased intracranial pressure and a pseudotumor syndrome, a secondary pseudotumor cerebri, if you will, and you stop the medication, you put them on Diamox, they get better, they stay off the medication, you stop the Diamox, and the papilledema gets worse again, and it turns out it was primary pseudotumor cerebri. So just because somebody's on a medication that could cause it doesn't mean it has.
As far as the CT venogram is concerned, that is a lot of radiation. MR venogram without contrast is probably suboptimal too. I have a deal with my radiologist where when we order an MRI scan of the brain for elevated intracranial pressure, they'll do post-contrast SPGR imaging, which gives an amazing look at the veins. And you can really tell quite well whether or not somebody's got a venous thrombosis. They will always have the narrowing at the transverse sigmoid junction where the veins get compressed probably by elevated intracranial pressure. That can be a nice, helpful radiologic feature of high pressure, but that you can get the information in one scan if you play your cards right.
We wrap up, Dr. Lai?
Sure. So there's a few take-home points just to kind of keep in mind that idiopathic intracranial hypertension is a diagnosis of exclusion. So as kind of what we've already discussed, you have to rule out all of these other things. So if you're saying it's papilledema until proven otherwise, you have to rule out brain tumor until proven otherwise, other secondary causes before you can call it IIH. And then there are some pertinent history findings that you need to keep in mind, but even if those things are positive, that does not completely exclude the possibility of something else causing the intracranial hypertension. We also touched a little bit about optic disc drusen or other pseudopapilledema types of cases. It can mimic papilledema and does not completely exclude increased intracranial pressure, and in this kind of case, you should always still consider papilledema until proven otherwise.
Thank you.
Neil and Judith, would you have her take her Norplant out if it was Norplant and not minocycline?
Yes. Yeah, I read.
No.
I'm worried about that drug.
And our next speaker is Dr. Melissa Coe from Indiana University.
All right, well, good afternoon, or morning, we're almost there. So my case is kind of similar to Kevin's title. My vision's blurred, sorry, Neil, and one of my optic nerves is swollen. I have no financial disclosures, and this is a public service announcement between me and Admiral Akbar. This is our final case of the morning and potential diagnostic trap, and then there's lunch, so hang with me. Okay, this is a 30-year-old gentleman who presented in the middle of the night to the emergency room, complaining of decreased vision of the right eye for 2 days. He states there was pain associated with eye movements, and preceding the vision issue, he had headaches. He also mentioned some generalized fatigue. His other history, no medications, so I guess that rules out the drugs of bugs and drugs. Past medical history and past ocular history, none. Family history, non-contributory, and a remote past history of intravenous drug use. On examination, his acuity was decreased in the right eye to 2400. Color vision was also dropped in the right eye. There was a right relative afferent pupillary defect. Motility was full, and his anterior segment did show +2 anterior chamber cell. Here's the appearance of that right optic nerve, where we can appreciate some swelling superior, nasal, and inferiorly. And his visual fields, where we can appreciate that blind spot is definitely enlarged and moving paracentrally. So I was just going to turn it over to the panel at this point for any comments about the differential diagnosis.
Were there other signs of intraocular inflammation besides the anterior chamber cells? Was it vitritis or vasculitis or parsplenitis or any of the other?
Such good questions, Dr. Volpe. No,
There were none.
none.
So, I think if I saw somebody, and I'm thinking about Admiral Akbar here, I'll be dismissive of true, unrelated, obviously, but, obviously people can have two different things. But if you have evidence of intraocular inflammation associated with an optic neuropathy, it triggers a very specific differential diagnosis between the usual suspects of inflammatory causes and infectious causes. And if one of my other colleagues wants to walk through that differential diagnosis, I would certainly be thinking about syphilis and sarcoid as primary need to be ruled out, regardless of anything else on the exam, but there are lots of other things in the differential.
Yeah, you heard earlier today the issue of extensive testing versus non-extensive testing. This is when you combine evidence of an intraocular inflammation with evidence, and make no mistake about it, it's an optic neuropathy, you have an RAPD, you have changes in the disc, so you have an optic neuropathy with inflammation. You're talking about many of the things that Mark tested for in terms of his assessment of optic neuritis: Lyme disease, sarcoid, syphilis, TB. These are things that you have to think of once you see that anterior chamber inflammation. And we as ophthalmologists, at least many of us as ophthalmologists in the room, we're the only ones who are going to see that inflammation. So if the neurologist, unless the neurologist is a card-carrying neuro-ophthalmologist and has access to a slit lamp, that person isn't going to see the inflammation, and that changes the whole ballgame, as Nick said, in terms of if you weren't going to work up the patient extensively with routine optic neuritis, this ain't routine.
I'll just throw in one other thing. In my experience, high-risk behavior is high-risk behavior. He has a history of IV drug abuse, and taking a sexual history on this man would be probably a good idea. And I'm not going to call him a gentleman until I've got that history well in the bag.
And I'd also point out, I think there's unique significance to being anterior chamber cells. There are a significant small subset of patients with idiopathic optic neuritis, demyelinating disease, that can have a splash of vitreous cells and some periphlebitis and things that are peculiar to certain HLA types of patients who get optic neuritis and multiple sclerosis. But there's inflammation in the anterior chamber. You have to connect the two, except for the rare circumstances where it's unrelated, which is...
So I think we have an ARS question coming up, so
Yes,
maybe
we
we'll ask
do.
the audience what they think.
All right, so how would you proceed? 1, obtain neuroimaging. 2, perform a lumbar puncture. 3, obtain a chest x-ray. 4, obtain a skin biopsy. 5, initiate IV steroids. Or 6, obtain blood work. I know I gave you a lot of choices. Okay, well, it looks like we were divided between obtain neuroimaging and obtain blood work. All right, we'll go forward.
I think I would have done that as which one of these is not true, because there's probably only one thing on there that I wouldn't consider doing in my first set of steps, which would be a skin biopsy.
Right.
So the testing results in the emergency room, the patient had a non-contrast head CT, and that was normal. MRI brain study unable to be obtained because of retained metallic fragments. A lumbar puncture was performed that evening, which showed a normal opening pressure. The CSF composition showed the absence of any white blood cells, 2 red blood cells. The protein was elevated at 84 with normal glucose, and the cryptococcus returned negative. Any other comments right now from the panel, or I'll keep
We're
going?
waiting for the blood
I
study.
know you are.
Are you holding back on us?
You know, there are things that I didn't even tell you yet. All right, so in terms of the testing results, the blood work obtained, complete blood count and metabolic profile, unremarkable. A very elevated sedimentation rate and C-reactive protein. An ACE level returned normal, the HIV pending, Lyme negative, ANA negative, so there was a little bit of extra testing there as we thought about atypical causes.
But there's one thing that's missing, as Judith said.
Well, hold your horses there, Neil.
Okay.
Hold your horses. Just giving everybody time to catch up. All right. So, question. I know, because we have to draw this out for 15 minutes, so I had to kind of think. Panel, would you treat when you're not sure exactly what you're treating? This is the middle of the night. The person's 2,400. The things you want, you're not going to get back right now.
An RPR?
What are your thoughts?
So are you trying to put time pressure on a neuro-ophthalmologist?
I'm just
This
going to
is why
say.
we go into this.
Well, this is a true case, true story. I was the fellow. It was the middle of the night, and I had to make some decisions. So
Just because it's the middle of the night doesn't mean you can't wait for the blood test to come back. And there's a really good reason. Like, the most obvious thing that you might treat would be optic neuritis, ordinaire with steroids, perhaps. I think that there are some circumstances where steroids are best not applied until you get the results of your testing back. And this is one of those cases.
Yep.
High risk, BB in the eye. Come on, BB in the eye, IV drugs. Hello.
any other comments from the other distinguished panelists?
I mean, if it turns out to be syphilis, then steroids will make him better while he's waiting for his penicillin. So I don't think I am not concerned by delaying treatment by 24 hours, if that's what you're asking me. But again, not sure that you would have done anything terrible if you did do that.
I think the main issue is to recognize that this is not typical optic neuritis. If you want to treat it with steroids for 24 hours, fine. I wouldn't.
Yeah, I wouldn't.
But I think the key is to recognize this is something different from the standard optic neuritis, and you need to follow through with it rather than simply saying, here's a prescription for 40 milligrams, 60 milligrams of prednisone a day, come back in 2 weeks, we'll see how you're doing.
The audience wants to know if MOG and aquaporin 4 should have been tested.
Well, back in 2009, no. No, it wasn't.
How often do we see anterior chamber inflammation
Yeah,
in
I don't know
MOG?
I don't know the
Certainly
answer.
not in NMO, I wouldn't think, but MOG, I don't think so. So I think the presence of the anterior chamber reaction is really significant here, and I would not have thought of testing for MOG or NMO.
The audience also wants to know, could this just be uveitis and you're seeing just swelling in relation to
Not with that amount of vision loss. Really.
Well, not without cells in the
Vitreous,
in the
right,
vitreous.
yeah.
I mean, if you've got an intermediate uveitis and you've got cells in the vitreous, then sure, you could have some mild disc swelling. But that's what Nick asked at the very beginning. Was there any other evidence of inflammation? In the absence of posterior vitreous inflammation, no.
All right. So, due to optic nerve swelling, he was treated with 1 dose of IV methylprednisolone overnight. This is real world, okay? The next morning, he was noted to have the following on physical exam. So this may be difficult for you to see where you are, but I'm going to get this arrow going. But you can see that he has a macular-papillary rash there on his hands and a desquamating type of rash on his
So is
feet.
he in a general ED, Melissa?
He is in
or an ophthalmic ED?
This is a general ED called HUP. All right. So rash on the body, including hands and soles of his feet, and now he's providing this history the following morning. Oh, that's been there for 6 months. The HIV rapid screen returned back positive due to the presence of the systemic rash, newly diagnosed HIV, history of IV drug use, as Judith was talking about, and RPR TPA serology sent returned back positive. The CSF VDRL non-reactive, and just for those in the audience, that's a very highly specific but not very sensitive test. So up to 70% of cases can return back non-reactive. He was treated with IV penicillin G for 14 days. We did go forward and continue just completion of a methylprednisolone course, and he, 5 days into treatment, showed improvement of his visual acuity, color vision, as well as his anterior segment exam and optic nerve swelling, and at 2-week follow-up, his acuity in the right eye returned back to 20/20. So final diagnosis, no trap to this panel, syphilitic optic neuropathy. Couple take-home points. Manifestations can occur at any stage of syphilis and involve any eye structure. Optic nerve involvement can be unilateral or bilateral and present, as Nick's questions earlier on was trying to get at, whether it's perineuritis, anterior, retrobarbar, optic neuritis, and retinitis vasculitis. The uveitis part, which we've highlighted here, plus the optic neuritis, certainly increases that clinical concern for syphilis. You have non-treponemal tests and treponemal specific. And just as a quick reminder, the non-treponemal, once you're treated, those titers go back down to non-reactive. The treponemal specific tests, once you have tested positive, remain positive. So we use those as sort of right and left hand and obtain both. The LP and CSF studies are the definitive way to be able to diagnose neurosyphilis, and we talked about treatment. The benefits, there's some literature going back and forth. I think the main thing is that treating them, as Neil said, with steroids and then just sending them out and leaving would be bad. There's many reports of worsening, but certainly a brief course. In some instances where the spirochetes are dying, you can, without steroids, there are rare instances of that reaction occurring. And then there's delayed immunity, so one can have re-exposure to syphilis and can lead to reinfection in that initial 3 to 6 month period. So I just wanted to acknowledge my moderator here, Colin, for providing some images here. May the force be with you. Lunch is just around the corner.
And to recap our session is Dr. Peter Quiros.
Well, thank you, everyone, for attending this morning's session. Just to recap this second session, bugs and drugs, do they matter? We learned from the first case that, these are my financial disclosures. They are not relevant to this discussion. And finally, in the first case, we learned that medication review and social history are really key, especially when we have patients with a bilaterally, slowly progressive process that doesn't fit with quite the basic clinical picture. And then stopping the incident medication in these cases may improve vision, actually. So there's a very good reason to pick up that phone and have that discussion with the prescribing physician. Just telling the patient is probably not enough. In the second case, we learned that myriad constitutional symptoms and diplopia, especially in an elderly patient, should always raise concern for Giant's arteritis, and that choroidal non-perfusion on fluorescein angiography can actually be very useful in suspected cases, especially when the visual symptoms are vague or maybe even absent. In our third case, we learned that we need to look at the scan, and I think that was reiterated throughout the session, or at the very least discuss it with the radiologist. Remember, Dr. Cockerham pointed out, radiologists look at films all day long, and it's picture after picture after picture, and unless they're told what to look for, they may not find it always. But if you just call them up and say, hey, can you look at that apex one more time? Because that's where this lesion looks like it's present. You sure that apex is clear? And you can feel much better about that scan being truly negative. We don't expect you to be able to read these scans because you don't do it every day. And then also biopsy. And if it's negative, maybe biopsy again because they may not have gotten the right amount of tissue. In our next case, we learned that patients with papilledema often have normal vision and maybe even minimal visual complaints, and that these patients can have drusen, and drusen patients can still have papilledema. This is where an FA, which is your test, can actually be very helpful to differentiate the patient that has only drusen or the patient that has true papilledema. And always remember to ask about secondary causes, as topical medications, oral medications, and supplements can often have an effect on intracranial pressure. And finally, we learned that optic neuropathy with intraocular inflammation, it's syphilis, 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 as my uveitis specialist, Dr. Holland, likes to say. But you must consider infectious and inflammatory causes in these cases. And in cases like this, it's okay to hold off for a few more hours on that treatment to wait for that RPR to come back, because they do come back pretty quickly. The lab's very happy to call you when that titer is 1 to 1,000 dilutions. And finally, if we could please have the point-counterpoint question back up for you to vote one more time. And that point-counterpoint question was, should NAION be treated with medication? Yes or no? If you could please weigh in. I'm going to weigh in as well. And we'll see if we changed any minds in the next few seconds.
What was the percent before?
And our results are, well, it looks like we didn't move mountains here. But the vast majority, I think, people agree that because there's no proven treatment for this disease, we really shouldn't be grabbing for straws, because we really should be doing no harm. So I want to thank you all for attending the morning session.